I think it's a little less than that,
It's probably less than that. Yeah. Chance
but
of being 100.
it doesn't matter because the corporation has deemed that one has to have a flu shot. Uh, and I guess the commercial is upload your evidence that you've had the flu shot to the Dropbox and Typhon.
Yeah. So I'm glad you went ahead and said that. We are we are recording, so we appreciate those of y'all for coming to tonight's lecture. And we just want to announce for everybody, you need to go into Typhon and upload into your profile. There's a little spot to upload your license, which you can just print off the computer screen. You can do a screenshot, or I don't know if your state where you are actually sends copies, but Alabama doesn't anymore. So you can upload a screenshot of your current active license. We need a copy of your CPR card, and we need proof that you've had the flu or why you didn't get the flu. Upload it into Typhon clinical sites. We're getting some HR is delaying students start, so please be sure you go in there and upload that. It's a requirement actually of the MSN program. So anyway, that being said, good evening, good Tuesday evening to everybody. We're going to start Unit 2, is what the computer says right in front of my face. So we're going to transition into the other end of life spectrum, to child adolescent assessment, some things that make assessment of children a little different from adults, and diagnoses most commonly presented, acknowledged, treated in childhood. So the PowerPoint was in the module under the PowerPoint's little tab. If you want to grab that, there's a couple little additions, not a major thing. I can post this version afterwards. We just mainly want y'all to, some of what we're going to talk about tonight is not testable. It's just for your knowledge going forward, so you're familiar with some things in your clinical. Who in the group? We got Karen, Morgan, Sabina, Thomas, Carmen, Deborah. Which of you, any of y'all working with kids last semester or this semester? Anybody here have some experience in your clinicals yet? I know Thomas is probably all adult. Karen, I think you've been all adult. Morgan, you're starting this week. Excellent. Excellent. Not yet, not yet. Last semester, first adolescent yesterday, 17. That's a fun age. All right. So we want to cover, and we have the next, tonight and the next 2 weeks, we're not going to get through this whole PowerPoint tonight. We're going to just get it through as much as we can. Mainly we'll focus on development and assessment components and ADHD. We'll try to get through at least ADHD, and I will need y'all's help on a couple of case studies toward the end, okay? Now, when you're studying for this, we're not going to test you on really nitpicky stuff of when does this reflex go away, or when should they, the child has said their first words. Would they be 8 months, 9 months, 10 months, 13 months? We're not going to do that kind of level of detail. But when you're going through, what you want to take home as you're reading SATIC, page 1086, or is that a C? Yeah. Page 1086 of SATIC is where this top super summarized box came from. And so that's where you will go if you want to familiarize yourself with, well, when should they have a first word, or when should they have a social smile? When should that show up? Or when should they be walking? Or what's the normal windows for those? You want to know normal because if you're working with a child and they haven't, here's the thing. Kids are going to have a lot of contact with the well checks and the pediatrician. The pediatrician is going to be the one 99% of the time who's going to say, yeah, your child hasn't really even started using single words and the child's 26 months, or the child hasn't even, pulled up to stand and they're 18 months. The pediatrician is going to be the one to really say, okay, this is a developmental issue, and then probably refer the child to neurology, not necessarily to us. But when you're interviewing, if you say you're working with a 3-year-old, I think that's the youngest child I've ever seen in practice has been a 3-year-old. You do want to have in the back of your mind, how many words in a row should this child of this age be, making accurate, correct grammar, syntax, how, when you're asking the parents about their developmental history, you'd always want to know, were they full term? Were there any complications, prenatal or perinatal? Were there, and then you would ask them, when did they reach all these milestones? That's information you'll get from the parents. But it'll probably, hopefully, would have been identified by the pediatrician and then maybe sent to us for other behavioral issues. So you can flip through SADC 1086. These are kind of the main ones. By 4 months, when we're talking about autism and social communication and expression of affect and those kinds of things, you can pay attention to about 4 months. The child should respond to, from mom. By 4 months, the child should be smiling. And if they're not, then that's a delayed social communicative behavior. Worth noting, because a child may come for behavioral problems or kind of what seems maybe more like a hyperactive impulsive ADHD, but you also want to know kind of generally where should they be with language and with play, so that because there could always be a comorbid developmental kind of component too. So that this box, just if you want, no, come back. There we go. This top box, this is SADC page 1086. These age ranges down here, do y'all remember one of the ways that we conceptualize cognitive development in kids? He's French, came up with a whole theory. Piaget, if that is a familiar contributor to really how he was the first guy who kind of looked at kids at different ages playing and saying, wow, they seem to interact with the world differently. They seem to make sense of the world very differently. And he came up with a very helpful category system of generally what to expect kids' behavior to be, and to help you interacting with them to remember how they're viewing the world. Little ones, toddlers, 2, 1, 2, 2.5, up to 3. You can say that's in the sensory motor. Piaget would say that's the sensory motor stage, when they interact with the world based on what they see and what they feel and what they hear and tactile sensations. There's not a lot of internal speech going on. There's not mastery of symbols by any stretch. A 2-year-old is working with the world, what's there on the screen. They want to move things, they want to run, they want to physically interact with the world. As they transition into preschool and they start to master language, there's the capacity for thinking, because thinking is just talking in your head. You need language to think, and language is symbolic. It's just sounds, that means other things, it represents other things. So at around 3 to 6, they can start having fantasy play. They can be creative. They don't really know how the world works as far as things like, you can play, you can play magical, impossible things, because if they can think it in their head, then it's real. There's not a good understanding of math concepts. There's no concept of logic. There's not an appreciation for conservation of matter and those more advanced, concrete sort of things that school-age kids, they start learning about. They start learning about math and how to move forward and backward with math, addition and subtraction and equations, and water and ice, that's actually the same thing. Little 3 and 4-year-olds, you're not going to expect that. So also if you want to interact with a preschooler, fantasy, creativity, let's play, let's draw, that's a good way to do it. It's not until maybe 6, 7, and older that an understanding of logic or rules about if this, then that. If this happens, then that will happen. Antecedent and consequence. It's not until they can understand how concepts relate to each other that children can start predicting outcomes of things. If I take this candy from the counter, then I will probably get in trouble. So let me not do that. That forecasting ability and consequences of behavior, that won't be present in a 3-year-old, but a 2nd grader, 3rd grader ought to be there. So what does that really mean, though, from a behavioral standpoint, is if kids aren't really expected to predict consequences and outcomes, and not complex sorts of outcomes, like global warming or anything like that. But if they're not expected to do this, to say, ooh, if this happens, then this is going to happen. It's like keeping 2 scenarios in your head at the same time. If you can't do that, then it's really going to be hard to have any impulse control. It's going to be difficult to follow the rules that the teacher says. It's going to be difficult to inhibit yourself and think about consequences, because if they don't develop that skill here, they might look like they're not listening. They might get into trouble a lot. They might look impulsive. They might disrupt class. And 7 was historically the age, 6 actually, was it 7? Doesn't matter now. That was about the age when you could start diagnosing ADHD in kids. Was at this transition where they should be able to inhibit and think about consequences and those kinds of things. So it's no surprise that the deficit in that forecasting if-then rules, when that deficit shows up is when ADHD was previously really, that was kind of the cutoff point. But what they found is that it doesn't show up. They were having some false negatives by leaving the cutoff that early, so now it's 12. But anywho, and then the next age, adolescents, 11 or 12 and up, and these aren't hard and fast ages. You'll see preschool 2 to 7 sometimes. You'll see school age 7 to 12 sometimes. Just, you want to know that preschool is not 8, and school age isn't 4, and adolescence isn't 9. You want to know the main cutoff buffer zones. Adolescents should have a very good mastery of language and of rules and if this, then that. So they're kind of advancing to, okay, well, I understand how the world works now, and present versus future and consequences and things. So who am I and how do I fit in relative to everything else? And that's what the most important thing to an adolescent is. Who am I, and I'm going to be me, and how am I fitting in to the people who I identify as my peer group? Erickson's developmental stages, we're not going into this, just piggybacking. The ones you should really focus on are the stages here: preschool, school age, adolescence. Because when you're working with kids, pretty much all of them with whom you work will be 3 to 17. So I hope that makes sense. But I just think it's helpful when you're working with kids who are coming in and they're really struggling. Think about what's the most important thing to them. The most important thing to a school-age child, according to this theory, is to just be good at stuff and get hobbies and be good at them and not get in trouble at school and be successful and have my parents say, ooh, you did a good job. Adolescence, not so much. It's I am my own person, and I am going to really separate from my parents. I have a separate, unique identity, but this is who I am moving through the world. That's what adolescents are shooting for. And a lot of times their problems are related to those challenges. Just some kind of tips. If you want to look in THPAR, the pediatric book, child adolescent book, page 410 in that THPAR and Pine book, really good chapter as far as things to consider in the assessment of children. What you're looking for, how to approach talking to your first intake with a 4-year-old versus an 8-year-old versus a 14-year-old. And this is kind of an overview of that. It's not a long chapter, but this is sort of an overview of that. Young kids who are 3, 4, 5, 6, not quite school age yet, they may still be real freaked out by new people. They've never been here. They may have had crummy experiences at doctors before. So you start by having them with the parents, because the parents are going to be the ones to give you all the history. And regardless if it's a young child or if it's a school-age child, when you'd probably want to start, this is just how I do it, but for young kids and school-age kids, and even for adolescents, the start of the interview, you have the child and the parent or parents in the room just to kind of introduce yourself, say this is the purpose of our session, and just say, kind of what brings y'all in today, because that shows that you're not on the parents' team. It's real important for rapport building with older kids, adolescents especially, that they know you're not just an extension of their parents, and they're not just dragging you in so you can force their parents' will on them. You're on the kid's side, and everybody's working together to just kind of show that. But then you'll separate with school-age kids. You can hang out with them. Adolescents, you really need to spend a lot of time with them. But young kids, the parents will need to give you the history, and you're trying to look for who talks a lot, who sits next to who, is there eye contact, does there seem to be tension between the parties, does anybody interrupt each other? You're just trying to get a feel for kind of the power structure, the dynamics of that family system. Because when you're working with kids, you're really working with families. And people tend to do, when people get nervous, they do more of what they kind of their default. So if someone's in your office and they seem to be showing kind of an extreme form of a certain behavior, that's probably what they do at home on a regular basis, and it just gets amplified in your office. Deborah's saying the mom was constantly cutting him off. The stepdad was there, and the mom was constantly cutting him off. Yeah, that's a situation where it can be necessary to politely interrupt the parent and really put some structure down and say, well, I'm really curious to hear from you, so and so. Because that's also modeling appropriate communication, that you let the person finish before you jump in, and it's showing that the kid's voice is really important and you were there to support the child. 17-year-old may as well be a child. You know what I mean. But yeah, people are going to do in a session, it's a microcosm of what they do the rest of the time. So things that seem dysfunctional in front of your face is probably dysfunctional at home too. Opportunity for education and modeling and those sorts of things. So young kids, if you want to build rapport and if you want them to kind of chit chat with you a little bit, you need a background activity going. Just sit on the ground and play with cars or Legos, or have a basketball hoop on the door of your office, or have a dartboard, or have cards, or have paper, and have, just stuff. Because that's really how young kids interact with the world, is in a physical sort of sense. Older kids, not older kids, I mean older than that, 6, 7, 8, 9, 10-year-old kids, you can interview them, just them. It's helpful if you have the opportunity to have a dollhouse in your office with different kind of figures there, and just say, show me who lives in your house. And just no pressure, let them take their time. Don't lead by saying, so your mom really fusses at you sometimes, huh? Or you were really, boy, I don't want to say that. I would, because none of y'all would ever say, you've been really bad at school. You'd never say that. Open-ended, non-leading questions. How's school going? Who's your best friend at school? What do you do during recess? What's your favorite class? Or show me who lives in your house. Or draw something. The book, I think, talks about the 3 wishes question. If you could have 3 wishes, what would they be? If someone could grant you 3 wishes, what would they be? And just kind of see what the child, there's a projective element to some of those. You just want to see what is prominent in the child's thinking. And you're looking also, when you're playing with kids, you're looking for patterns in their play. Is it organized? Are they real hesitant to initiate play? Are they real free? Are they real creative? Are they real literal? Are they sticking with one activity pretty well and following it through? Or are they, no, I'm done with that, and then I'm on to the basketball, and then I'm on to the carpentry set, and then I'm on to the color pencils. That's relevant information to observe. Is it real disorganized? Is it kind of chaotic? I was working with one little boy who was going through this box of toys. If any of y'all have ever heard of Playmobil little figurines, they have all sorts of themes of toys, cowboys and Indians and race car drivers and pirates and all this stuff. He went through the box and just picked out all the guns and just laid out in a row, like they're half an inch long, they're tiny. So that was, so something about guns. It could have been a gun in the home. It could be news he shouldn't be listening to. It could be people talking about things that they don't need to be talking about in front of him. But it's certainly, it warranted some further exploration with the rest of the family, because I think that child was 4. But that was, yeah, Deborah said video games, maybe so. At this point, I really don't remember. But when you leave it open, what comes out is going to be probably the most prominent thing for the little person. And they think it's fun, and they'll want to come back and see you. Another thing you can do is have a treasure box full of toys that you get from the Dollar Tree. And at the end of the session, the child gets to pick a toy from the treasure box. And they will be it's just about making your interaction with you comfortable, and they're willing to come back. As far as adolescents, they're probably not going to trust you. So you want to be non-judgmental. You want to be authentic. You want to show that you are, that you're really there to help them. And this HEADS screening tool is a pretty neat mnemonic of things that you want to be sure to check in on with adolescents, because that's when sexuality begins to express itself. I mean, I guess it could be younger now. You probably have to assess for that, more like sometimes 9 and 10 and 11. But by standard, for sure, with adolescents, how is it at home? How's school? Any drugs, sexuality, thoughts of self-harm. And what's neat about that is you can ask them, well, do your friends ever get into that kind of stuff? What do your friends think about drinking? Do your friends ever do that on the weekends? Or have your friends started, are they starting to have sex with their girlfriend's boyfriends? It's less threatening to ask about what their friends are doing than it is to ask, well, how about you? So, and these are things you're not going to touch on in the first session anyway. Remember the goal working with kids more than adults, because this is a really weird environment for them, more than likely. So you want to focus on rapport. Any questions about any of this stuff that we went through so far? Okay, I'm not trying to go quick, but it is a good bit of information we're trying to cover in these 3 weeks. So just remember those age-related norms. kind of activities or approaches that are more appropriate with a 3-year-old versus an 8-year-old versus a 12-year-old. Don't use real big words with preschool and school age kids. Don't talk about real abstract concepts. Keep it pretty literal, keep it present, keep it concrete with younger kids, and then expand as they get older, or as they, as they can tolerate. You may work with some really precocious, bright 8-year-olds with great vocabularies who like to think about stuff that most 8-year-olds don't. But authentic, really appropriate, really important. It's okay to be funny. It's okay to make jokes. It's okay to make fun of yourself a little bit if that's something you normally would do, just to kind of break the ice. And in that SADC chapter, talking about kind of emotional language mastery, a lot of problems kids face are due to an inability to put language to their feelings. And when you're working with them, something that can be helpful is if they're starting to get frustrated with a game, you're playing Connect 4 or something, and they're starting to get frustrated, or they laugh really big at something, or they look a little scared or concerned, to reflect to them, you're really enjoying this. You're happy doing this. You're getting angry with this piece of this puzzle, or to help them start associating the language for the word, for the emotion, to the behavior that they're feeling. Because a big issue kids have is having to find some other means to express sadness or fear or frustration because they don't have the words for it. Which tells you the environment has not been capable of communicating that, how to express those things in the home. So the parental interview, which is necessary when working with any child or adolescent, is to get an adult perspective. So what brings the child in? What's the reason for the referral? Thapar does really good in their chapter talking about this. And it's important to speak to the parents in the absence of the child or adolescent as well, at some point in each session. Because the parents can tell you when did it start, contributing factors, how's school, how are grades, kind of that social. This is in the PowerPoint posted in the course. None of this is magical necessarily, but it's information the child can't give you. Sorry about that. Really helpful to get information from teachers. Schools, a lot of schools will use the Vineland or the child behavior checklist. In the Thapar book on page 424, it's not a chapter that you have to read at all, but more for your reference going forward. On page 424, they list different scales for ADHD or for depression or for anxiety, or just kind of general functioning scales, some of which are free. So if you sort of want to have a go-to of some assessment tools, Thapar and Pine, page 424 has that for you. Is there any family psychiatric history, mom, dad, brother, sister, ever treated for ADHD, ever treated for anxiety, those kinds of things? And if you look at families as systems, and some systems, when they're under strain, if they're lacking a resource, if there's a deficit to it, like with any structure, the the fault in the system will manifest itself in the weakest member, which is always going to be the child. So you want to always consider the child as a member of that family, and the child in a context that may or may not be, the system may or may not be able to promote healthy functioning in that young person. And you're going to be limited in the advances that you make unless you try to address some environmental, systemic, mental health, communication kind of deficits. How does mom and dad deal with sadness or anxiety? How do they handle conflict? How do they handle punishment? How do they handle praise? All those kinds of things. Because the child is just doing what they've seen and what the system has fostered them to do. The identified patient, like Dr. Fogger said. Yeah, definitely. Whatever state you live in, be sure to know the age of consent, because that once you're a medical age of majority, then you don't have to tell the parents really anything. So in Alabama, any minor who's 14 or has been emancipated can give consent to any mental health service, and the consent of no other person is necessary. So that just means confidentiality is necessary. Sabina, you saw a lot of patients who used their children's time for their own therapy. Imagine. Yeah, if people would take, Dr. Fogg and I were talking about that today, if people took better care of themselves, it's amazing how that would ripple out into other people. So those of you who've seen kids, what are some of the common reasons, or what do you think a common reason would be for a kid coming to see y'all of any age? Behavior problems, so angry outbursts, okay? Real common is, those behavioral issues, certainly. Academic problems, right, because that's kids' jobs. The kid's job is school. Can't pay attention, especially when kids have made it to school age. They're getting into fights at school, or their grades are crummy and they're forgetting things and they're not listening and all that. Fighting with behavior problems, inattention. We're going to talk about mood issues down the road, and tonight we'll focus more on ADHD. Uh-oh. There's an angry Maltese in this house. Sorry, everybody. I'll mute it if she keeps that up. So, ADHD. More Blue Cross of Alabama, I think in 2016, said more medical visits were due to outpatient at mental health. Like a third of them were for ADHD. And then every other mental health condition was lumped into the other 66. So a lot of people are getting diagnosed with ADHD. A lot of parents are bringing their kids to treatment for ADHD. As a psych specialist, you're only going to see kids who are probably really young, like 3 years old, that the primary care doesn't feel comfortable writing a stimulant, or someone who's been through a couple of trials and the pediatrician is like, you should probably go see a specialist. So it'll be really rare that you get a child for an intake at your office who hasn't tried anything at all. Deborah's saying maybe they're applying for disability. Maybe so. That's true. And it could always be a parenting issue. it can always be the system. The odds are best that it's a systems issue. So you just want to be sure. You just want to be sure that you assess the family and the coping and the what's the routine, what's the schedule, how are things reinforced, how are things kind of what's the rules? Is it promoting these behaviors that the parents say are of concern? So more boys tend to get it than girls, anywhere from 3 to 6 or 4 to 8% of school-age kids are diagnosed with it. It just seems like a lot more kids are diagnosed with it than that. And about half, 50, 60%, keep symptoms into adulthood. Real common comorbidities are oppositional defiant disorder, anxiety is real common. Now it's primarily an impairment of inhibition and self-regulation. It's an executive kind of function problem. What I'm going to try to do, not breaking anything, because we're talking about dopamine and norepinephrine. When you think dopamine and norepinephrine, what do you think of? Anything come to mind? Oh, this is what I want to do. Excitation. Yeah, energy. Energy. Kind of, oh, that sounds good. I'm going to do that. Yeah, let's do that. And that's a big part of the impulsive component to ADHD is difficulty with regulating this impulse is okay and should be followed. This impulse is not. It needs to be downgraded from higher structures who were thinking about consequences and taking in other data. Like, oh, this is not an appropriate time to jump up and yell the answer. So, ta-da! Even if you just Google, real easy, there's this great website that I found called, I think this is it, Medical Key, basicmedicalkey.com. And this you get just from Googling ADHD, norepinephrine, ADHD, dopamine. And it's crazy because what I found is the exact same pictures from the ADHD chapter in Stall. So, do you remember the disorders that the disorders that dopamine is implicated in? Kind of the big ones we talked about. Too much dopamine, yeah, that might look, or not enough dopamine might look like schizophrenia. It could look like excess energy. It's kind of implicated in bipolar disorder to an extent. Addictive disorders, again, dopamine and the nucleus accumbens, that is your pleasure reward center. This is a good idea. This is not a good idea. The frontal cortex needs just the right amount of norepinephrine and dopamine innervation norepinephrine coming from the locus coeruleus and dopamine coming from your midbrain. It needs just the right amount floating around in the frontal cortex to have the right mix of attention, of, ooh, that's important, I should pay attention to that. And I'm going to keep paying attention to that. That's what norepinephrine helps, to help kind of enhance the signal of, the thalamus is taking in all this sensory information. Your frontal cortex communicates very closely with that. You need norepinephrine to be alert, to be sharp, to be attentive. So when there's not enough norepinephrine, there's going to be a problem with, oh, that's important. Let me do that. I'm going to pay attention to this and keep it in my head. I'm going to keep working with these multiple concepts in my head. Like, if I do this, then I'll get in trouble. This math problem, this chapter I'm trying to read in my geography book, whatever it is. You need enough norepinephrine to be excitable and strengthen the signal of, let me keep paying attention to this stimulus. So you need norepinephrine. Another thing, dopamine does a couple things too. It helps with response selection. When we talk about the striatum, that came into play with movement issues, not only with schizophrenia, but those extrapyramidal symptoms like Parkinson's disease. People have trouble initiating movement. They have trouble filtering out movement or choices they don't want. That's what dopamine helps you do, is filter out things that you don't want. Have any of y'all ever cut grass on a riding lawnmower? Okay, thank you, Karen. Where I'm from, I cut a lot of grass on riding lawnmowers and tractors, actually. Would you ever listen to music when you were on the lawnmower? Well, pretend then. One time. Okay. If you're on an airplane, if you're in a really loud car and you're trying to listen to music, there's two ways for you to hear the music. One is to turn the volume way up so that the signal is higher, and the other way is to lower the background noise. Like turn the lawnmower off, and then you can hear the signal better. What dopamine helps do is lessen the background noise so that the signal, the intention, is strongest, and the person can stay focused, stay attentive, and not be, or maybe distracted by this impulse, or, ooh, well, I want to do that, or, hey, that looks interesting. So that's how dopamine and norepinephrine work together to inhibit noise and to inhibit other thoughts, other impulses, other motor programs, and to stay tuned in to the action at hand. So you really need both. And that is appropriate because all the main ADHD medicines address both. That's how you address both. And you can imagine that if there's too much, because there's some instances, and Stahl talks about this, and this is largely hypothetical, but in some instances, maybe the person had too much norepinephrine, too much dopamine for too long. And anytime, what happens when a cell is exposed to too much of a chemical? What will the cell do if its receptors are exposed to too much of the chemical? Anything ringing a bell? Well, if they're already being overwhelmed, they're going to say, woo, I'm going to burn up unless I become less responsive to that chemical. So they'll downregulate. So the idea that too much norepinephrine and dopamine is not a good idea either, because it may result in downregulation. So ta-da, in the end, you still end up with not enough norepinephrine activity, strengthening the signal, the attention, the selective attention, not enough dopamine to help with this filtering process. So let me see if I can get back to where we were. I hope so. Dun, dun, dun. Okay, there we go. So that's just medical key, basic medical key, which neat. It's kind of the same stuff as in Stahl. This picture from Stahl talks about the particular structures. These are all in the prefrontal cortex. That anterior cingulate cortex for selective attention, it becomes active when something enters the field that the person needs to pay attention to. It's your salience network. It's real important with attention. But then these motor, when you see motor, you think, that may be more of I think dopamine might have to get involved when we're talking about motor selection. These are just the symptoms of ADHD. All of them. Is that not there? Okay, we'll leave that right there. You can have ADHD predominantly inattentive presentation, predominantly hyperactive impulsive presentation, or ADHD combined presentation, meaning a combination of both. But you've got to have 6 of 12 inattentive or 6 of the 9 combined hyperactive impulsive symptoms. The Vanderbilt is a really good scale that's also free, that you can have parents and teachers fill out. The symptoms have to be present for 6 months, not just at school, not just at home, at least 2 settings, with the symptoms present before they're 12. Because this is ADHD is being viewed as a neurodevelopmental disorder because of inappropriate pruning of certain neurons. It's not something that you get at 15. It is present from birth. And the great thing is there's a lot of behavioral interventions and medications that are really helpful. What's new to DSM-5 is the symptoms have to be present before 12, not 7 anymore. There's something about, I guess, transitioning into 7th grade. Would that be 6th grade, 7th grade? There's something about getting into junior high that a lot of inattention seems to become real evident at 11 and 12 that maybe wasn't detected at 7 or 8 in school just because the cognitive demands were not so great. Because once you have to start, you're changing classrooms, now you have a locker, you have 7 subjects, you have more complex math. This thing is sensitive, holy moly, sorry about that. So you may see a lot of kids coming in at 5 thinking about ADHD. And in those cases, it's probably a more hyperactive, impulsive presentation, bringing in the younger kids because they don't have a real demanding schedule, and school's not hard. There's not a lot of homework. There's not a lot of reading. But once all that changes and math, papers, different books, different classrooms, my locker, and they're more independent. Yeah, they have to really start self-regulating at that point. But causes impairment, grades are bad, social is bad. They keep misplacing things. They're in detention. They can't go to swim practice anymore. They can't go to football practice anymore because they're so disruptive and they're kind of staying in everything. It has to cause impairment. And social impairment can be significant from this. We mentioned those screens. Again, younger preschool kids, it's going to be more of a physical manifestation, that inability to inhibit impulses. There's no inhibition of do this, do that, that looks fun, I'm talking, there's no filter. As they get a little older, the cognitive demands increase. You'll see more reported concerns about misplacing things, losing things, forgetting things, not finishing things. They may make friends and then lose friends because they're not waiting their turn to talk. They're not able to attend to any kind of social cue. They might be impulsive. Kids might think they're really funny because they'll say anything and they'll do anything, but from a more personal level, they may say things that are hurtful. They may not remember conversations because they weren't able to attend to them. School age and adolescents in particular, how do they keep track of their things and how do they keep track of time? Do they lose things, misplace things? And are they able to stick to a schedule? Are they running late everywhere? Those kinds of things. And that lack of impulse control is a concern because of how that may make things that have a lot of stimulation provided, like, oh, you better not smoke at school, oh my gosh, that's things that kind of evoke a dopamine release. Things that are exciting are going to be very appealing because excitement actually makes some folks with ADHD feel normal. With some people with inattentive ADHD in particular, it may make it worse. But things that are stimulating, video games, they have a lot of light, they have sound, they have drama, they have an easy scoring system, they have, medals that you can win, they have special ammunition that you can win. They have special whatever, special powers you can earn and all this. They're very stimulating. It doesn't require sustained attention because it taps right into the reward center on its own, and kind of keeps the person tuned in. So folks, sometimes they'll say, oh, they can't pay attention to anything, but if you give them a phone, they'll sit there quietly, hyper-focused almost, for hours and hours and hours. And into adulthood, that impulsivity work can be a problem. Trouble meeting deadlines, trouble maintaining, responsibilities with relationships. Substance use, because again, anything, if there's an intrinsic deficit in dopamine and norepinephrine contributing to these symptoms, stimulants are very attractive to these folks. They may do a lot of caffeine. They may find themselves taking other people's stimulants. I've worked with folks who say, yeah, I did meth and I felt normal. So not only is there the lack of really consideration for consequences, people often seek out the chemical that balances, that provides a balance for whatever excess or deficit is in their own central nervous system. People who are really, really anxious, way amped up, go find GABA when they drink alcohol. People who have issues with attention and impulsivity are often very attracted to stimulant medications because it helps them focus and have more control over their lives and their decisions. So if you can correct that, you can greatly reduce substance use trajectories for adolescents and kids if you can address that physiology with a medication that you can control. Because think of the risky things that adolescents are doing anyway. They're starting to drive. Oh, my word. Oh. Differential diagnoses. Is it normal? Well, you can do a screening and let you know, is this beyond normal? Anxiety is real common, which can relate. Social anxiety is real common too, largely because they may have not a real good track record of social interactions. They may not be able to attend to cues. ODD is common, and there's a reason for that we'll talk about when we talk about stimulation is helps with clarity. All of us with a little bit of anxiety, a little bit of norepinephrine going up, we all focus better. We all attend better. That's a survival mechanism. If something kind of gets the amygdala to say, oh, scary, and suddenly your attention is better, that helps you survive. So if creating conflict kind of helps you think better, you may create conflict. This is a new slide. We'll post it later. Not a huge deal. This is the slide we have to put on there. Initial monitoring for stimulants, because that is the first line treatment for children and adolescents, is going to be stimulant medication. For people over 18, it's going to be non-stimulants, just because there is risk of exposing people to stimulants, because very, very habit forming, and the non-stimulants can help, like Strattera and Wellbutrin can help with inattention, which is often more problematic in the 50 to 60% of people into adulthood who still exhibit symptoms. It's much more likely to be an inattentive presentation than a hyperactive impulsive presentation. But norepinephrine and dopamine goes up, appetite goes down. So you need, before you start, get a physical exam, height, weight. You want to get a weight and a height anytime you see them, if you see them every 3 months. Contraindications for stimulants are going to be like a cardiac conduction issue, because this can affect norepinephrine can speed up conduction time. Seizure disorders, anything that increases dopamine lowers the seizure threshold. So seizure disorder, you would want a neurologist or a cardiologist to clear you to write those medicines before you did. I worked with a kid who had he would just get SVT, but it was a single little spot, and they did an ablation, and his cardiologist said, yeah, it should be fine for him to get back on a stimulant. And I said, okay. It might increase your blood pressure 3 millimeters mercury. It might increase your heart rate about 3 beats per minute. It's not a tremendous increase, but it may be noticeable. But you really got to check for appetite because of how appetite suppressing it is. Main side effects: anxiety, irritability, insomnia, decreased appetite, stomach ache, those kinds of things. And sleep disturbances are real common for kids with ADHD anyway. So melatonin's good. Some of those, that'd be a good place to start. Make sure there's a real consistent bedtime routine as well. But sometimes folks will use, in addition to melatonin, they'll do clonidine at night. They'll do one of the non-stimulant, more sedating ADHD medicines at night too. And when a stimulant is getting out of a child's system at the end of that time, they might get pretty irritable. So what seems to be helpful is to, in the afternoon, schedule some kind of physical activity for the child instead of just sitting and being sedentary and getting real aggravated. This slide, this and the next one, I'll post it. This is not, the main thing we want you to know is the difference between amphetamine, the amphetamine family, which is your Adderall, just these things we have listed here, with some trade names, some of which are really new. What makes the amphetamines different from the Ritalin family, the methylphenidates, they both block the reuptake of norepinephrine and dopamine. Well, that's good. So you end up with more norepinephrine and dopamine at the synapses to act. That's good. But what the amphetamine family does differently is the actual molecule itself gets taken up back into the presynaptic neuron. Stahl shows you pictures. And when the molecule gets into the presynaptic side, kind of the action side of the neuron, it is able to trigger more norepinephrine and dopamine to be released, which is different. Not only does it block the reuptake, making whatever is available stay available, it makes a little more pump out. That is why the amphetamine family generally is stronger than the methylphenidates, the Ritalins, the Concertas. They might work better, and they often are less tolerated because it makes kids more anxious or more irritable. In the literature, you'll see AMP for amphetamine. You'll also see MSA, and that stands for a mixed salt amphetamine. And that just means right here where you see Adderall and Avikio, kind of like escitalopram versus citalopram. One is a left-handed version of citalopram, and then citalopram is the left and the right mirror image. In amphetamines and methylphenidates, the dextro, which is the right, like ambidextrous, most people are right-handed. D means right. The right-hand shaped isomer is about twice as strong as the left. And in amphetamine, the D isomer ends up affecting dopamine more than norepinephrine. So anytime you see a dexedrine, or there's more D than L, more dextro than levo, that means, ooh, that's probably pretty potent, because that's kicking a lot of dopamine out. Mydayis is a brand new drug. It's been on the market not very many months, and it actually has an initial release of amphetamine, and then 4 hours later another release, and then 4 hours later another. It's the first ever triple pulse ADHD medicine. So they say it should be good for 16 hours, is what they say. This is just your methylphenidate family, your Ritalin, your Concerta. There's a patch form of Ritalin. There's a liquid form of Ritalin, essentially. There's a chewable form. And actually, there is a dissolvable form of amphetamine, of the Adderall family. It's not sublingual, but say you have somebody who a child who doesn't swallow pills, or for an adult who's on a really busy schedule and sometimes they can't be around water for some reason. So these companies just try to keep coming up with different delivery systems. So that's the difference. Methylphenidates don't actually cause more release. They just, all they do is inhibit the reuptake. These are just examples of duration of action of these are all methylphenidate products. Ideally, you would have kids on a long acting because that gives them, you're not having this peak and trough and then stacking another peak and trough on it. It's also easier. You give it in the morning and it lasts them all day. They don't have to deal with go and see the nurse at school. So long acting is better. It's smoother. And these just show you with the Ritalin family that this newest one, Aptenzio, they say it's going to work for 12 whole hours. So extended release is the best. And then there's non-stimulants. Adults with a substance use history, that's a great idea to try that first. These non-stimulants, alpha-2 agonists, kind of sort of act like norepinephrine. Strattera, which is a norepinephrine reuptake inhibitor. Remember, norepinephrine is more associated with sustained attention and strengthening the signal. It's not as associated with reducing the noise or the competing signals. So Strattera, or Wellbutrin, which is largely a norepinephrine reuptake inhibitor, that's going to be more helpful for someone with an inattentive presentation. That's probably not going to help a super impulsive child. So just some things to think about. It has its place. Someone who can't tolerate a stimulant, someone who has a substance use competing condition, but it tends to cause a good bit of GI distress, and it can be pretty sedating initially for people, not unlike how Effexor can be pretty sedating for people. No abuse potential, doesn't exacerbate tics. So real quick, this will be the last thing that we do. So here's an 11-year-old girl. She's 11, and her grades have declined this year. She feels overwhelmed with homework. She does church choir, she does soccer, she likes time with her friends. No behavior issues, no substance use. So this is a real active 11-year-old, or just real quick, kind of any other information you would need to confirm a diagnosis? Let's say it's ADHD, but what one particular piece of information would you need? She's having problems with schoolwork. But with ADHD, oh, definitely, yeah, you want to get grades. With ADHD, it has to be in more than one setting, right? Before age 12. And just from a prescribing standpoint, not so much a diagnostic standpoint, but it's an 11-year-old girl. And yeah, exactly. How's behavior at home? Is she overwhelmed with tasks at home? Is she disorganized? Is she forgetting things? Is she running late? You would need to establish an inattentive presentation in more than one setting. No behavior issues, so no. Oh no, you're fine, Morgan. Because she's overwhelmed with homework, her grades are bad. But how does her inattention manifest otherwise? No behavior issues, which tells you it won't be an inattentive or hyperactive presentation. So do you think she would benefit from, she's having issues with attention only? Okay. Any of those medications that you think might be appropriate for her? Parents are down. Inattention only. Strattera, you could do that, certainly. That'd be a good start. You're not really needing to get at impulsivity at all. Some other things that you consider when prescribing for kids is, do they need a medicine? Do they need a short acting or do they need a long acting? Long acting is always best, in particular when you're working with kids who have a lot of after school activities. A lot of those long acting, those extended release medicines, you're only going to get about 8 hours of coverage. They'll say they're good for 12 and 14, but a lot of times 8 is good. So you'll end up doing a long acting in the morning with a booster dose of an immediate release after lunch to try to help the child get through football practice, get through homework, those kinds of things. So for an active, socially active young person, Strattera is an appropriate thing to try because it works more like an antidepressant works, which means it'll be an all-day thing. Takes 3 or 4 weeks to really see the benefit, but Intuitive could certainly be an option. What we find is that Intuitive, the guanfacine, the clonidine, have a real sort of sedating component, especially clonidine. Intuitive not as much because that's guanfacine, which is less, it doesn't affect those alpha-2 receptors that tend to cause sedation. But yeah, it's good that you have options because you may work with a family that you interview the child, you get reports from school, the grades, you think, this little girl she's going to need some sort of pharmacotherapy, not just getting her a schedule and a calendar and a routine and having the family help and having the teachers help. You put all those things in place, the behavior supports, but it's still not going to work. You may have parents who say, I don't want her on a stimulant. Stimulants make me nervous. Then you have options. You have Strattera. You can give that a shot. You have Intuitive. You can give that a shot. Shouldn't be as sedating. Might be. Some kids take it at night. Some kids take it in the morning. Clonidine will be sedating, but it's worth a try. Typically for attention, stimulants really are first line, but you may have parents who just don't want to go that way. Or the child is really low weight to begin with. Or there's some other, contraindication. So you have options. But yeah, y'all are both thinking along the same lines. And then you can give it a shot, give it a couple months, redo a Vanderbilt scale, see how she rates, check her grades again, check the teacher's reports, and if it's better, wonderful. If not, you'd want to go a long-acting stimulant would be the way to go. She can take the weekends off, and you always want the child to go ahead and eat breakfast, then take it. And then once they get home from school, they'll probably be starving because they won't have eaten lunch because their appetite is so suppressed. And they'll just want to eat you out of house and home in the evening, and that is okay. Whenever they're hungry, you let them eat. As opposed to Matt, and then we'll be done. Appreciate y'all hanging out a little bit later. 5-year-old, he's always into something. He can't sit still. He's moving constantly. He also won't follow directions. It's like he's not even listening to you. He misplaces things. Goes in his older brother's room and takes his toys, but then he loses them and he has trouble sleeping. But then there's, when you interview the family, he has trouble sleeping, but then there's no pattern whatsoever at home. Sabina, just following up on that last one, you wonder if it's too many activities to make them feel overwhelmed. You're exactly right. You do want to check. You do want to see, are the expectations realistic? Is sleep enough? But something to just kind of file away is a lot of times women with young girls and women with ADHD. This isn't everyone, but it's a pretty common report to say, I just feel really overwhelmed. That there is, it's not a diagnostic criteria, but to say I feel overwhelmed with blah is, you want ADHD and inattention issue to be in your differential there. So that was mainly to introduce the overwhelmed kind of litmus test. But here is a 5-year-old boy who's up and down and left and right and getting into people's things and not following rules and losing stuff. You need some limits, need some structure. Yeah, you always have to make sure the environment is supporting appropriate behavior, or is the environment supporting the reason for the referral? Then you're going to have to give a lot of family education. The PAR and Pine talks about that. Family education is so important. But anything jump out? Here's a little 5-year-old. After further assessment, it's ADHD with a combined presentation, and he's having trouble sleeping. Any thoughts? About somewhere to start medication-wise? This might be a good opportunity to do one of those non-stimulants at night. Sure, might be a good opportunity for that. To give it a shot. The clonidines and the Intunives, they can certainly help with inattention, but the odds are better being a little more on the sedating end of things. They tend to help with impulsivity more than attention. They can help with attention, but that's more of your go-to if there's just a lot of impulsivity. So one place to start, try to help with the sleep and that activation at night with an alpha-2 agonist. And then the family will come back and say, yeah, that didn't really help him very much during the day. Hadn't helped him enough. Then you would go with one of the stimulants that are indicated for a 5-year-old. A lot of them are indicated for 6 and up. Not as many are indicated for kids 3 and up. So when you look through your stall prescriber guide, dexedrine Vicchio is indicated for 3 and up, but you're a little more limited from a FDA standpoint. You're a little more limited for 3 and 4 and 5-year-olds. However, those of you who've worked with child psychiatrists, yeah, Morgan, exactly. Those really are the only ones that are 3 and up. Vicchio is almost considered a milder form of Adderall. But if y'all are interested in it, I'm happy to talk with you about that separately. Why Vicchio is a little different in that way. But those of you who've worked with child and adolescent psychiatrists, do they always follow FDA guidelines? Not at all. And 5 is right on the cusp. So depending on weight, you will totally go off label as far as ages go. And just with younger kids, remember, these are strong medicines in little kids' bodies. So from a risk-benefit standpoint, you want to be sure that the environment is supporting appropriate behavior, schedules, structure, prompting. There's a super cool book called It's by Alan Kasdan, called Parenting the Defiant Child. It's an awful name, but it's a great book, Parenting the Defiant Child. You want to be sure the environment's supporting the appropriate behavior. If you want to go non-stimulant first, do it. Absolutely do it. There's nothing wrong with that unless it's a safety issue and the child is, having pretty intense tantrums or they're running into the street and it's a safety concern. Then you would want to go, oh, first line stimulant, let's do it. So there's a lot of material, but I really wanted to get through that so we can pick up with developmental disorders next time. I'll go ahead and post this other version of the PowerPoint because it has that other medication information on it. Any questions or pressing issues that y'all wanted to bring up before we say enough is enough? Good thinking on those case studies. They were super brief. I really just wanted to talk about things you kind of think about when you're prescribing these medicines. These aren't going to be, we're going to go over the rest of them next time. Yeah, we're just going to pick up where we left off with autism spectrum for next time. But any questions? I know a lot of y'all haven't worked with kids too much. If you have any questions about the assessment stuff, the medicine stuff, why this medicine versus that, questions about prescribing practices, please don't hesitate to email me. I'll be happy to go over that additionally with y'all. So, okay. Anything else, Dr. Fogger?
Just if anybody's interested in the American Psychiatric Nurses Association membership, it's $25. You email me and say you want to become a student member, and then I write a letter and set it up. It will help when you apply for ANCC certification because there's a big reduction if you're a member of the American Psychiatric Nurses Association. So it's a year's membership, and it's a lot easier to get it done now than wait to the last minute. So that's my commercial.
I like it. All right. Y'all are champs. We're going to stop the recording and see y'all next week.